Hello to everyone who's connected. On behalf of the VASCERN coordination team, I'd like to welcome you to this VASCERN webinar on the classification of vascular anomalies with presenters Emir Haxhija and Paolo Gasparella from the Department of Pediatric and Adolescent Surgery at Medical University Graz in Austria. So first, we'll have just a few general reminders. If we could just change it to the next slide. So just a few general instructions to let you know the webinar will be recorded. So if you want to watch it again, or you have colleagues or friends who missed it, it'll be available on our YouTube channel and website. Also, that any questions that you have, please type them into the chat box because we'll have a time at the end to answer the questions, and it's less disruptive than having people speaking. And finally, if you have any technical issues, please also, you can type that in the chat box and or send an email to myself, and we'll try to help you with those issues. So first of all, just a quick intro before the scientific presentation starts to introduce who we are. So this is the VASCERN, the European Reference Network on Rare Multisystemic Vascular Diseases. We're one of the 24 ERNs, and we gather 26 healthcare providers, full members, plus 7 affiliate partner members coming from 16 EU countries. We're also gathering 70, well, more than 70 patient organizations from all across Europe, and they are part of the European Patient Advocacy Group, or EPAG, who collaborate and are members to representatives in each of our 5 rare disease working groups. So our network is divided into 5 rare disease working groups, as you can see on this slide. We have HHT, which is a hereditary hemorrhagic telangiectasia, HTAD, heritable thoracic aortic diseases, MSA, which is medium-sized arteries. They cover mostly vascular Ehlers-Danlos syndrome, and PPL, which is pediatric and primary lymphedema. And then today's group, which we'll be presenting, is from the Vascular Anomalies Working Group, or VASCA Working Group. And they cover more than 40 rare vascular anomalies diseases. So all more information can be found on the website, of course. So we recommend you to take a look if you haven't already. And we're very lucky today because to present the Vascular Anomalies Working Group, we have the chair himself, Professor Miikka Vikkula, who will give a quick introduction to the VASCA Working Group and its members. So I'll pass the word to you, Miikka, now.
Thank you, Natasha. I think everybody hears me. So the VASCA and VASCA group is really a very important collaborative group that does all the work together. As you can see on the slide, so we have 7 full members, so full centers, multidisciplinary centers in the EU, and 1 affiliated partner center, the one that is presenting today, the first VASCA and VASCA seminar. And we are evaluating about 7 other full centers currently, so we might become a network of about 15 centers soon, I hope. And so with Laurence Boone here in Brussels, I chair this working group with very tight interactions with Leo Schulze-Kuhl, who's our co-chair from the Netherlands. And then we have the different centers in Finland, in Sweden, in Ireland, in Germany, and in Italy. Those are the full centers. And then we have the affiliated center in Austria. And the work is really geared towards trying to make guidelines and expert opinions for vascular anomalies, the field that we are all working on our vascular anomaly multidisciplinary centers, trying to distribute information to physicians, to experts, but also to non-experts, and also to patients. And so we have very tight collaboration with the patient associations. You can see 5 photos on the right side of this slide. We have 3 vascular anomaly patient associations in the Netherlands. We have the HEVAS, we have the LGDA and CMTC. We have the VASCAPA in Belgium. And then we have the Bundesverband Angeborene Gefäßbildungen from Germany. So this EPAC group is very essential, of course, so that we hear patients' voice. And as you heard from Natasha, the VASCERN.eu website has most of the information that we have already published or are producing. So if you are interested in it, go to that website and try to find information from there. And there you also find a link to contact the group, for example, Natasha. Today also the EPAC group has a special day. They have made a digital magazine of 76 pages, and it is published today. You find the link on the VASCERN website. It's really written, made conceptually, and the content by the patient associations, of course, by interviewing different physicians in our network and getting some draft text also from the physicians. And so there's a lot of information of various types in this magazine. So please download it, read it, give feedback, because I hope that the EPAC group will follow this activity and even create other magazines in the future. So further ado, I would then like to just pass over the presentation to Emir. So he's a professor and a pediatric surgeon in Graz in Austria, and with Paolo Gasparella. So they are taking care of this multidisciplinary center in Graz. And so Paolo will be then available also for the questions and answers at the end of the presentation. Thank you.
Miikka, thank you very much for this kind introduction. I would like also to greet all participants and of course to thank you for this opportunity and a chance to talk in the first VASCA webinar about the classification of vascular anomalies. I must say that we have nothing to disclose, and I intend that we go out of this lecture today by knowing what vascular anomalies are and what the term vascular anomalies means, how they are classified, and why do we actually use a particular classification, because there are many classifications of vascular anomalies out there. So far, we have personally not been involved in developing any of the published classifications of vascular anomalies. So I can say for us that we are not biased on this, which classification we use, depending on that, which one we developed ourselves. Potentially, of course, only as users, because if you get used to one classification, you like to stick to that one, but there must be always a reason why we use one classification. But before I enter to this, I would like to come back to the VASCERN website and the part of the VASCA working group we are involved in. I want to tell you that there are many important information that you can get out of our website. Among others, also information about the vascular anomalies, the rare ones we deal with. You can see what is the incidence of them in the European Union, what is the prevalence of a particular anomaly in the European Union. Then also you have a direct link to the Orphanet website, where when you click on that, you get, for example, here you have cutis marmorata telangiectatica congenita. And when you click on that, you go directly to the Orphanet website, and then you can see the definition of this disease. Then you can see the summary, the short summary about this disease, but not only the short summary about the disease, also you can find links to detailed information about this disease, and also links to additional information about all these diseases. Therefore, my lecture today will not intend in discussing the diseases in particular, but discussing the classification in general. And then I would really very much like that when we leave this, this lecture today, I'm not sure that I'm going to be able to cover it exactly as I wanted, but maybe we can clarify some things in questions and answers section. But I would really very much like that at the end you see what are the possibilities about mixing up various vascular anomalies, the confusion which can be there if you do not know much more about vascular anomalies, and how you can differentiate between different vascular anomalies so that the patients do not suffer. On our VASCA website, you can also see a section with short educational videos, which are very nice. We call them pills of knowledge. And you have short webinars about the classification of vascular anomalies, a short version of that, what we will talk about today. Then a diagnostic approaches for vascular anomalies, the multidisciplinary expertise teams for vascular anomalies, how they composed and how they should be composed, and also a short video about a management of vascular anomalies with many more short videos to come. So the science is actually in all fields of medicine continuously helping us to change our views and of course improve our work. So probably this, what you're going to hear from me today, might not be like that tomorrow, because we are evidencing that actually the molecular basis of the vascular anomalies is rapidly getting discovered. This leads inevitably to changes in classification, mainly today based on new genetic disorders discovered. And these new genetic disorders discovered are opening also new opportunities. It can be that they are not only going to provide a more precise classification of vascular anomalies, but also they could be the basis for targeted treatment with specific drugs in future. We are evidencing the beginning of that kind of treatments also today. So what is the term vascular anomalies meaning? It is actually an agreed term. It's an umbrella term for any kind of pathologic vascular birthmark or vascular marks, which doesn't have to be a birthmark. It could be a vascular mark which is acquired in adolescence or in adulthood. So any vascular birthmark, umbrella term, vascular anomalies. So it is not actually the same like when you say somebody has a heart anomaly or a kidney anomaly, because here we think there is an inborn malformation or anomaly, and it is a congenital malformation anomaly, because anomalies and malformations are usually synonyms for other areas. But when you talk about vascular anomalies, with people dealing with vascular anomalies, they will know that they still do not know much about the patient. They do not know if the patient has a vascular tumor or a vascular malformation. If you say a vascular anomaly, it is, to my opinion, similar when you just say, we have a milk product. If we have a milk product, you know that the milk is the ingredient, but you don't know really what kind of product it is. Is it mixed with some other ingredient which you could be allergic to? You don't know still the size of the product. You don't know, does it fit to your household and so on. So you have to define it further so that you know what you are talking exactly about. Patients with vascular anomalies have always attracted physicians' attention, but it was in the past the inability to understand the differences in etiology and pathohistology and behavior of various vascular anomalies, which led to confusion concerning the need for their treatment in general, and also in particular, what kind of treatment the patient should receive. It was in the middle of 19th century, I cannot but mention this, when Virchow and Wegener made a very important distinguishing between hemangiomas and lymphangiomas. They analyzed so many pathoanatomical appearances of vascular lesions and came to this conclusion. They very nicely found out that there are vascular lesions composed of blood tissue and vascular lesions composed of lymphatic tissue. And they further also recognized and characterized various vascular lesions into simple ones, the simplex, and then the cavernous ones, like very large cavernous type, and the racemosum, which would be vascular lesions in clusters or in bunches, which everyone who deals with vascular anomalies today knows that it is appropriate for many of patients with vascular anomalies. But they could not at that time know some other details, which Malikin and Glowacki were so able to recognize and present to us in 1982. They proposed the biological classification of all vascular lesions based on the clinical appearance of the vascular lesions, natural history, and also cellular characteristics. So they divided all vascular anomalies into two separate entities, completely separate entities, into entity of vascular tumors and the entity of vascular malformations. So in the upper part of the picture, you see vascular tumors, and in the lower part of the picture, you see vascular malformations, which is intermixing. But It's completely different. Dr. Malikan from Boston, together with Dr. Young from England, at that time, already 76, started a biannual meetings with specialists who were interested in treatment of vascular anomalies. And these biannual meetings just transferred into the biannual conferences and workshop of 1992 founded International Scientific Society for Vascular Anomaly. The ISFA, called shortly International Society for Study of Vascular Anomaly, her latest classification of vascular anomalies was updated in the year 2018. This is the classification we use in practice because it has turned very valuable to us. And I hope that after this presentation, you will understand that what can you gain out of this classification, and what is this classification still not offering you, in meaning how to treat then a patient according to this classification. So what we are going to discuss until the end of this lecture is a 20 pages document, which is readily available at the ISFA website and downloadable for everyone. And the very important note is at the beginning of this document is that this classification is intended to evolve as our understanding of the biology and genetics of vascular malformations and tumors is going to continue to grow. So what we see today and what we can read today on the website and out of this document might change next year when the next ISFA meeting is going to take place. So this is the overview table, the first table showing us that the division of vascular anomalies into vascular tumors and vascular malformations is the main division of vascular anomalies we all should know. And then the vascular tumors are then subdivided into other groups, into the benign vascular tumors, into locally aggressive or borderline vascular tumors, and into the malignant group of vascular tumors. And the vascular malformation have the division into the simple combined. Then there is a subgroup of major named vessels, which I will go into a bit later. And then a group of vascular malformations associated with other anomalies. So the main difference between vascular tumors and vascular malformations lies actually in the difference between infantile hemangioma as the main, lesion or the main tumor in the group of vascular tumors, because it is so common. The difference between infantile hemangioma and vascular malformations. The difference lies in that the tumor, the infantile hemangioma, appears mostly after birth, and it shows a fast growth after birth, and then it shows a spontaneous regression, which we still do not exactly know why it happens. And when you analyze it under the microscope, after you have a resection, it shows an increased endothelial cell turnover, while the vascular malformation is mostly visible at birth if it is on the surface of the body. If it is intramuscular or intra-abdominal, you will not see it, but maybe it will make problems during growth or adolescence. But the vascular malformation will grow proportionally with the child, unless it is again a special vascular malformation with localized intravascular coagulation, and then it will grow more. But then the vascular malformation do not show spontaneous regression, and they show normal endothelial cell turnover. So when you compare these two lesions, and when you know these differences, you cannot say for the lesion on the right that it is an infantile hemangioma or that it is a vascular tumor. You should know that it is not an infantile hemangioma because it was present at birth and it did not change much. Why I am stressing this point out? Because here you can make treatment mistakes. You can treat the vascular malformation with a drug against vascular tumors, and it will not work. And it will be a treatment, an unnecessary treatment, maybe not definitely harmful for the patient, but you will lose time and you will inform parents wrongly. Furthermore, if you resect infantile hemangioma and some vascular malformation, you will see that hemangiomas are GLUT1 positive, only the infantile one, and the vascular malformation is GLUT1 negative, which is a glucose transport protein. You see here the vascular tumors show spontaneous regression, a vascular tumor on the head, while the vascular malformations grow with the child and do not show a spontaneous regression. So let us go into details about the vascular tumors. The benign vascular tumors are infantile hemangiomas, as I said, the major candidate or in this vascular tumor, the main group. Then we have a group of congenital hemangiomas, which are rare vascular tumors we also deal with. And in the group of congenital hemangiomas, there is a group of rapidly involuting congenital hemangiomas, non-involuting and partially involuting congenital hemangiomas. The point is that you should know that there are congenital hemangiomas. If you do not know that there are congenital hemangiomas, you can again make a mistake and think that it is an infantile hemangioma and again treat them inappropriately. Then there is a group of tufted angioma. It's a very rare vascular tumor. Then spindle cell hemangiomas and epithelioid hemangiomas, which usually occur in adolescence. And pyogenic granuloma, it is a tumor known also as lobular capillary hemangioma, which we thought and we often see after some injuries or after some insect bites, and they bleed a lot, and usually we resect them surgically, but they have also a genetic background. What you can see on this table is that the genes which have been discovered to be responsible for these lesions are presented in these tables with blue, and they are also presented in this 20 pages classification. So when you click on the see details for infantile hemangioma, you will see that the infantile hemangioma has also a special appendix in this classification, and they describe the infantile hemangiomas as focal ones according to the pattern, how they are distributed, then a multifocal one, segmental hemangiomas, and then indeterminate infantile hemangiomas. And then also depending on are they only superficial or deep or mixed or even reticular or abortive hemangiomas, which show actually a very minimal postnatal growth and early regression. Here, you can also find the association of infantile hemangiomas with other lesions. They are defined into syndromes, actually. One is called face association. It is an infantile segmental hemangioma of a head. So taking 1, 2, or 3 dermatomes, and then it can be associated with various anomalies intracerebral, like here, Arnold-Chiari malformation, or intracerebral hemangioma making a hydrocephalus, or intraorbital hemangioma periocular, or very common, you see the anomalies of the supraortic vessels or the coarctation of the aorta. Here, the lumbar or pelvis or sacral syndrome, there are more associations today described than here at this 2018 classification of ISFA, which also are sometimes associated with intraspinal lipoma or even other anomalies like anal atresia or kidney anomalies, and sometimes even cerebral anomalies. Then the group of congenital hemangiomas, which I mentioned before, one should know that they exist. This group of hemangiomas is already completely developed at birth. And it just depends on how this completely developed hemangioma, which is seen at birth, is going to develop in the next months of life. Is it going to be called rapidly involuting congenital hemangioma, or non-involuting congenital hemangioma, or partially involuting congenital hemangioma? In the case of rapidly involuting congenital hemangioma, the picture on the top, you actually do not need to do anything because it disappears by itself. We have actually just to know that some of these rapidly involuting congenital hemangiomas could grow postnatally and because they could be associated with some consumptive coagulopathy and thrombocytopenia. And then sometimes it could be difficult to distinguish them from tufted angioma or some borderline vascular tumor. And maybe only the biopsy is going to distinguish it. But the majority of these tumors would disappear by themselves, while the non-involuting or partially involuting congenital hemangiomas are going to stay and will require a surgical resection for removal if the parents that wish. If you click on details by other benign vascular anomalies, you will find a list of many other benign vascular tumors, which I will not go into detail. They are, majority of them occurs in adolescence or adulthood, and the majority of them have different colors between blue and red and purple. And actually the pathological diagnosis will tell us what kind of benign tumor it was after it was resected. Usually that is the way they are diagnosed. The locally aggressive or borderline vascular tumors are called hemangioendotheliomas. That is the agreed term to use for these locally aggressive or borderline vascular tumors, and they are various. Yeah, the most common is the capochiform hemangioendothelioma, and these tumors are, by their name already characterized, they are locally aggressive or infiltrative. So they do not respect tissue borders and go through the tissue borders. And some of them have already a genetic background, as you see here, with the discovered genes. And very commonly, we will need a biopsy to know what kind of tumor it is. So the pathohistologic analysis of the specimen will tell us what kind of tumor it is, and they usually need aggressive treatment because if not treated, they have also a high mortality rate. The last group of vascular tumors is the malignant group of vascular tumors, like angiosarcoma or epithelioid hemangioendothelioma. They are characterized, both of them, by distant metastasis. Angiosarcoma is a very aggressive tumor. Thanks God, it is very rare. So you will rarely see angiosarcoma in your career, unless, at least as a pediatric surgeon, as a pediatrician. It is, of course, more common in adulthood and in geriatrics. Some vascular tumors are also associated with hematologic anomalies. There is an appendix 4 in this ISFA classification showing what kind of hematologic disorders are associated with what kind of vascular tumors. Here you see the tufted angioma, capochiform hemangioendothelioma, and rapidly involuting congenital hemangioma may be associated with mild to moderate thrombocytopenia or sustained thrombocytopenia with profound hypofibrinogenemia, and then elevated D-dimers like Caspar-Merit phenomenon. But also a number of vascular malformations we will later on talk about can be associated with very similar hematologic disorders. So these two groups can sometimes be difficult to distinguish from each other, and a biopsy will be needed. So before I pass to the vascular malformation, I just want to take your attention that there is a very nice NIH, so National Cancer Institute website where you can really find nice information especially for patients, about vascular tumors, especially childhood vascular tumors, but also adolescent vascular tumors. And there is also a section for health practitioners on this website. So let us see what is the classification of the vascular malformations on the ISFA website. So the simple vascular malformations are not simple in meaning they are easy to treat or something like that. They are simple in a way that there is a single vascular line involved, except for the arteriovenous malformations, where there are two lines in one, say it like arteriovenous fistula. So you have capillary malformations, like this child with a port wine stain, or a lymphatic malformations, like here on the floor of the mouth, or here in axilla, where you see the lymphatic fluid from the puncture coming out, or you have venous malformations, like here in a foot, or arteriovenous malformations, or arteriovenous fistula in this girl with the thigh. So you have to believe me that there is an arteriovenous fistula when I show you this photo, and I don't believe that I can convince somebody that this child could have an arteriovenous malformation of the fistula without showing you this MRI image, because this one can then convince you that the blood is coming into this arteriovenous malformations, and immediately the venous return on the left is occurring, and on the right side you see only the arterial branches. And you see here a strong arteriovenous malformation. So in the part of the vascular malformation, I will a few times point out the crucial role of imaging to distinguish between different vascular malformations. So let us see how the capillary malformation are classified. So here you can see that the capillary malformations could be a simple nevus simplex or salmon patch, like angel kiss or stork bite. There are different names for that. Also in different languages, there are different names for that. And this is also a kind of capillary malformation, even it is not really a disease, of course. Yeah. Then you have non-syndromic capillary malformation, known as port wine stain. And these port wine stains have been discovered. It has been recently discovered that it has a genetic basis. Majority of these capillary malformations have been already discovered to be somatic mutations. In this case, the GNAC gene is involved, and it is just the timing probably when the somatic mutation is occurring. If you will have a non-syndromic capillary malformation like here, or the capillary malformation is going to be associated with ocular anomalies or central nervous system changes, like in Sturge-Weber syndrome, as we know it, or if the capillary malformation is going to be associated with bone and soft tissue overgrowth or the whole body overgrowth. Then you have a group of reticulate capillary malformations, which could be associated with microcephaly or megalencephaly. And then you have a capillary malformation associated with arteriovenous malformation due to RASA1 mutation. Then you have cutis marmorata telangiectatica congenita, which is a disease which usually does pass by itself without any treatment, but could sometimes also be associated with hypertrophy of the extremity. Then you have other telangiectasias, and you have a hereditary hemorrhagic telangiectasia, for which there is a special working group in the framework of the VASCERN. And then, of course, in the ISFA classification, you will always have a group of others. You will always have a possibility to discover another capillary malformation with something else, which maybe in future even gets genetically based and gets to enter into this kind of classification. At this point, I want also to take your attention and to tell you that on the VASCA website, we have developed patient pathways. So these patient pathways are called also clinical decision support tools. And when I just mentioned the capillary malformations, here you can see that we have patient pathways for capillary malformation, venous malformation, lymphatic malformation. I will come back to those also in the other sections. And here the capillary malformation diagnostic workup, so that you find out actually your patient with a capillary malformation and some change, overgrowth or not, where does it belong? What will be the final diagnosis? In this case, it's the 8 pages document and easily downloadable from our website. So go back to lymphatic malformations, the second group in the simple group. They could be cystic. When I'm talking now about these simple vascular malformations, you have to know that this is always just a single strain. So this is a single strain, just lymphatic malformation, not involved with any other vascular strain. So here we divide the lymphatic malformation into the common cystic lymphatic malformation. They are also not that common, so these malformations in general are rare, and they are divided into the macrocystic, microcystic, and mixed cystic lymphatic malformation. So here you see patients with various lymphatic malformations, the one in the axilla, the one in the tongue, and the tongue and the cheeks and the neck, and the other one we can see here on bowel, around the bowel. And I will tell you that in the next slide that because from outside and without imaging, you cannot know if these lymphatic malformations are macrocystic or microcystic or mixed. To distinguish between that, you will need, or we will need, imaging. And it has been shown that these lymphatic malformations are due to mutations in PIK3CA gene, which is responsible for the majority of lymphatic malformations, but also for a number of overgrowth syndromes we will talk about a little bit later. So another group in the lymphatic malformations is the generalized lymphatic anomaly. The next one would be the Kaposiform lymphangiomatosis, or the lymphatic malformation in Gorham-Stout disease, where the bone is progressively being replaced by the lymphatic tissue, or the channel type lymphatic malformation, which is the central conducting anomaly. Another group called acquired progressive lymphatic anomaly, and a number of primary lymphedemas. With a group of primary lymphedemas, there is a special VASCERN working group, which I will just mention in the next slide. But before that, I would like to show how the imaging can tell us what kind of lymphatic malformations we are dealing with. So here, for example, in the upper image, you see a localized lymphatic malformation, which has a little bit bigger cyst and a smaller cyst. But you see it is localized on the back of the body, and it is not spread around, it is not diffuse. Comparing to that, this image is showing us a diffuse malformation attached to the pericardium and going through all tissues of the thorax. And these MRI images are showing us that this lymphatic malformation is macrocystic and microcystic. It is involving skin, subcutaneous tissue, muscles, the tongue, the peripharyngeal tissue, and so on. You can exactly see what tissues are involved when you use the imaging, and you know what you can do with treatment and what you cannot do. When you click to the other lymphatic malformations, then you will come to the primary lymphedema, and you will see many different primary lymphedema types, which you can distinguish from each other by, of course, genetic analysis and waiting to see that what genetic background, what lymphedema has. It's going to be a primary hereditary or lymphedema, dystrichiasis, and so on. And as I said, there is a pediatric and primary lymphedema working group in frame of VASCERN, and they have also already developed a patient pathway for primary lymphedema, which is readily downloadable from their website at the VASCERN. And our working group has developed the diagnostic workup for lymphatic malformations in general, so that, of course, one can classify with what kind of lymphatic malformation we are dealing. The next group would be the venous malformations, the simple venous malformations. These are the group of most common venous malformations, which is, again, I say rare. One calls them common because they are the most common ones we see in the practice, and much more common than the other venous malformations named in this table. And all these venous malformations have a genetic background, so all of them have a background of somatic mutations, which occur sporadically. Important to know for all these vascular malformations is that these sporadic somatic mutations occur in various parts of body. So you can have a common venous malformations completely the same in the cheek or in the foot or in the thigh or wherever in the body. And very commonly, you will not see two patients which have completely exactly the same. They are all a little bit different. They are all unique, at least according to my experience so far. And you have then another group of familiar venous malformations with cutaneomucosal malformations, a blue rubber blood nevus syndrome, which has also a visceral involvement, or a glomovenous malformations, which is very specific, and you can see it corresponds very well to the Virchow explanation of racemosus, or bunches, clusters. Then you have a cerebral cavernous malformation, familiar intraosseous vascular malformation, or a group of verrucous venous malformations, which were formerly classified into the verrucous hemangiomas. And of course, always the possibility to have other venous malformations which are not described in this table. Imaging is very important also for venous malformations. So when you see these two patients, you cannot really exactly know how this venous malformation is distributed. When you see the images, then you see here that you have a localized circumferential venous malformations in the thigh of this child. And in the next patient, you have a diffuse venous malformation. And according to how this is distributed, then you can also have your treatment options and you can decide what to do. There is also on our website very nicely developed patient pathway for suspected venous malformations, so that you can find the diagnosis, what kind of venous malformations you have in front of you. And the last group of simple malformations are the arteriovenous malformations, or arteriovenous fistulas, which have actually a very similar classification in this ISFA classification. These are the sporadic occurring arteriovenous malformations. This corresponds almost to the common venous malformations or the common lymphatic malformations, occurring sporadically in any part of the body without being associated to any other syndromes or something like that. And it has been shown that they are also genetically determined. And then you have arteriovenous malformations in the frame of hereditary hemorrhagic telangiectasia, or in the frame of capillary malformation, arteriovenous malformation syndrome. Or you have arteriovenous malformation due to which you cannot classify into these groups, and then it would be classified under others. Imaging is also here very important. You see this hip area which is swollen, and when you have an MRI image, you see that in the gluteal muscles, you see an intense image here, and then you see also that there is an intense image in musculus erector trunci, and then in the angiography, MRI angiography, you see an arteriovenous malformation, an early arteriovenous shunting from this left side with the vein coming back. And this is the basis then for the treatment, which would be then treatment by interventional radiology. The combined group of vascular malformation is nothing more than just the combination of these different types of simple vascular malformations I have just mentioned. So if you have a capillary malformation together with venous malformation in some part of the body, and the basis would be a sporadic mutation, then you will have a capillary venous malformation. If the capillary malformation is going together with a lymphatic malformation, then you can classify it as a capillary lymphatic malformation, and so on, all possible combinations between these different lines of vascular tissue. And also here, of course, imaging is very, very important. So you will see the arterial inflow into the foot, and then you will see a very early venous return, and you will see multiple, for example, in this case, arteriovenous shuntings, microshunts in this case, which is a case of a Parkes-Weber syndrome. And the whole foot was here involved in microshunting and is full with vascular tissue. So now I will pass to the vascular malformations, which are considered like a group of major named vessels. This one is based on Hamburger classification, and I am not really sure how the classification will, ISFA classification will look like in future on this point, because this part just describes the embryological basis of actually all vascular malformations. They could be a lymphatic or venous or arterial malformation, and the embryological source of the vascular malformations is described here with the origin, the number, the length, the diameter. Are there valves or not? Are there communications in fistulas? It is a kind of the tabular classifications, which is actually not described in detail at the ISFA classification. The last group of vascular malformation is comprised by vascular malformation which are associated with other anomalies. So we have a number of other anomalies like limb overgrowth, then we have bone overgrowth, we have eye anomalies, we have leptomeningeal capillary malformations, we have enchondromas, lipomatous overgrowth, or asymmetrical somatic overgrowth, macrocephaly, and as I mentioned also before, lipomatous overgrowth. And all these different associated anomalies are then associated with some vascular malformations. It could be all of them, lymphatic and venous and capillary and arteriovenous, or only a few of them involved. But what is interesting here and what you should know is that if you have a patient with a vascular malformation and some limb overgrowth or bone overgrowth or some asymmetrical somatic overgrowth, by doing a biopsy of this tissue, you could genetically, theoretically, if your genetic institute is going to deliver you this information, find what kind of mutation is involved in this tissue. And in this way, you can find out also if some of these vascular malformations associated with these anomalies are genetically based, and what is the genetical basis, say, of the disease or the patient that you are currently treated. But this is the only thing that you will know. You will not really know out of this how to treat the patient. So how to treat the patient, it's another story. For example, here a Klippel-Trenaunay syndrome, or here a patient with the Klaves syndrome. You see the specific feet looks like, and then you see epidermal nevus, and you see a capillary malformation, or a patient with the recently described Klappos syndrome with a capillary malformation of a lip, lower lip always, and then lymphatic malformation. In the group of, in the classification of ISFA, there is also an appendix showing the diseases with PIK3CA related overgrowth. So the mutation in this PIK3CA gene lead usually to overgrowth, and they're called like PIK3CA related overgrowth spectrum, or PROS group of lesions. And they are named here in a line like fibroadipose hyperplasia, and then hemihyperplasia, multiple lipomatosis, and so on and so on, so that I don't mention all of them. You can easily read about this group of diseases either on the ISFA website or online. Important is that they all have the PIK3CA mutation, and potentially, say, they could be, these patients could profit from treatment against the PIK3CA gene. And we will see how this will develop in the clinical trials which are approaching. So last but not least, when we go back to this main table, ISFA is also giving us a separate provisional list of few unclassified vascular anomalies. And I must say this is also an important list of diseases, vascular lesions. When you think of intramuscular hemangioma, it is not really seldom disease. And it is sometimes difficult to believe that an intramuscular hemangioma or an intramuscular venous malformations are difficult to distinguish from each other. But ISFA leaves space in this classification that some lesions are really not easy, still not easy to classify into purely vascular tumors or purely vascular malformations. It is still not really clear that experts cannot really agree if one specific lesion is a vascular malformation or a vascular tumor, or if one specific lesion, if it is possible that one specific lesion can have characteristics or parts of both. There are lesions which could have parts of vascular malformation, and some parts of that could be some vascular tumor. So this is an ongoing process. This classification is for sure going to change in the next years. So I hope I could have explained to you in these my presentation so far that we need the classification actually in the first row for the sake of our patients, so that they receive the best possible treatment for their vascular anomalies available at the present time. We need it also for our sake and for the sake of our colleagues, so that they can offer to their patients the best possible treatment they're aware of at the present time. And then for the sake of science, so that we can compare between treatment protocols used in different countries with the goal of continuous improvement of patient care. And then, of course, for the sake of our healthcare systems, so that patients receive best possible care on time, immediately, avoid complications in future, and also reduce cost of treatment. So I am here, and Paolo is here for questions. Thank you very much for your attention. I hope it was not boring.
Thank you. Thank you very much. That was a very comprehensive, interesting overview of the classification of vascular anomalies. So we do have some questions in the chat box. If you'd like, I can start with the first one.
Yes, please.
So non-involuting congenital hemangioma are basically resected only for cosmetic reasons. Are there distinct time lapses to wait and confirm the non-involuting in terms of how many months you would wait? And follow-up is preoperative embolization helpful in these cases?
Paolo, would you like to answer?
Yes, thank you very much for the question. About the indication of treating non-involuting congenital hemangioma, is the first thing to dealing with is to understand if it is a non-involuting, a niche, a non-involuting congenital hemangioma, and then the lapses of time is about of 6 months. In this time can normally understand if the involution of this congenital hemangioma is appearing or not. And then the indication is if you think, Dr. Kinesberger, if you think that a cosmetic reason only, you think of an eventual oncological transformation is not the case for congenital hemangioma, but there are also hemangiomas located in dangerous localization, such, for example, congenital hemangioma, also rapidly involuting, located in the liver, that need prompt treatment. I don't know if you are dealing, you are.
If I could also add to that, I think that what Dr. Kinesberger asked is very important, because he says that it's basically resected only for cosmetic reasons. And you're right. It always depends on where the non-involuting congenital hemangioma is. And of course, if it is in the face or somewhere which is cosmetically, where it's cosmetically obvious that it needs to be removed, it will probably need a resection but always the parents are the one who are going to tell us if they want to resect it or not. So, and there is no other treatment which we would be aware of, and resection is for sure much better than the embolization. I haven't seen any time the embolization, at least I haven't experienced that the embolization helped in niche cases.
Okay, thank you. There's another question that asks for molecular diagnosis. When biopsy is not an option due to high procedural risk, are there other valid options available?
Paolo, would you like to go?
Please, Emir.
Okay, so the biopsy is rarely not an option. So it could be that a surgeon is afraid of biopsy, saying, okay, he thinks that he's going to bleed a lot. But I have personally still not experienced a case where we could not do a biopsy. So I think that we can always do a biopsy. And I would not know of another. So imaging is one thing. So if you always want to have a diagnosis of a case. So if you are, according to the imaging, not sure what it is, for example, you have a case, because I have seen that the question continues with the PIK3CA mutation, if it is true. And if that is that question, yes, it goes with caposiform hemangioma. Sometimes imaging is not going to tell you exactly if the case is a caposiform hemangioma or it is an infantile hemangioma, but a very severe one, especially in the liver. And so, and then you want to know, because the caposiform hemangioma will have a worse progression in the liver or even somewhere else than only a capillary hemangioma. Even a big capillary hemangioma in the liver can make many problems and a heart failure too. But if the imaging is not delivering you the information you want to have so that you can continue with the treatment, because of course caposiform hemangioma has another treatment than infantile hemangioma, a completely different treatment, then we would go for biopsy. And considering the PIK3CA mutation, I must say that I am unaware that it should be, because as we all know, sirolimus is working very, very well in a caposiform hemangioma, but I am actually at the moment not sure if the PIK3CA mutation in caposiform hemangioma is regularly found. Maybe Miikka can help us here.
No, I don't. I'm not aware of.
Yes, I'm also okay.
Yeah, but perhaps somebody has. You don't never know everything.
Yeah, thanks.
Okay, great. So next question is, how do you best distinguish if it is a congenital hemangioma or if it is an infantile hemangioma, if the information from the parents are not clear?
Paolo, would you like to go?
Yes. Generally, the pattern of growth of these lesions are really characteristic. For congenital hemangioma, they are in the most cases already full developed at the birth, and typically hemangioma show a growth pattern after birth, and it's in my experience not really the case that the information are just partial from the parents.
Okay, but if I can add up, if the information from the parents is not clear, as you are asking, which of course can be the case, that you have a patient with a big hemangioma, and then you are not sure, and the parents don't tell you if it was present at birth or not. Depending on, of course, the age of the patient. So if the patient is 3 months, it is very important to know if it was congenitally there, or it is an infantile hemangioma, especially if it is a cosmetically difficult place, periocular or somewhere where it is very important. So if you can wait what the treatment is concerned, I would just make a photograph and then ask the patient to come in 1 month again or in 2 months again, and then you will see. Or maybe if you're afraid that the further growth is going to put the patient in danger, then I would just say the patient to come in 2 weeks if it is 3 months old. If it is an older kid, of course, then it can come later on. And also, if you have seen congenital hemangiomas often, then you will recognize a number of them, because the non-involuting congenital hemangioma, for example, which is there already at the age of 1 year and it is not disappearing, usually has somehow a white halo around the lesion. And then also from this white halo, you can say it is a congenital hemangioma. And also congenital hemangiomas are usually bigger. They're quite big lesions, actually.
Okay, great. Thank you. What about B blockers in hemangiomas? Are they really helpful?
Paolo?
Hemangioma, if we read about infantile hemangioma, nowadays is the gold standard therapy for treat infantile hemangioma. For congenital hemangioma, beta blockers are not the therapeutic.
Thank you. How thorough should the imaging investigation be when you see an apparently localized lymphatic malformation?
How what?
How thorough, like how much in depth, or how much do you need to do the imaging investigation? Is it something you need to really focus on?
Okay, first of all, the apparently localized lymphatic malformation should be defined. Anyway, the point is that if you really have apparently localized lymphatic malformation, say that this apparently localized lymphatic malformation is on the abdomen subcutaneously, and you do primary imaging will be an ultrasound because it is readily available. And if the ultrasound, if you do it yourself, then you can be sure. If you're not doing it yourself, then you will depend on the information which the ultrasonographer, whoever it was, the radiologist or somebody else, is giving to you. And if you rely on that information, and you can then decide what imaging, further imaging or treatment you want to do to the patient. I always like to have an exact, either I do the ultrasound myself, and of course, if it is only one cyst, then okay, I say it's a localized thing. And if I see multiple cysts and I cannot really localize them, then I make an MRI imaging. And the MRI imaging we do ask for just because we want to be sure of the extent of this lymphatic malformation, because we want the patient not to have a recurrence. We want the patient to be treated from the beginning on exactly as we want it. So if the healing is possible, then we want the patient to heal.
Thank you. Do you agree to keep the diagnosis of nevus simplex? It can induce confusion to parents.
Paolo? Okay, yes, I do agree.
I don't really understand the question, sorry.
Yeah, well, I do agree to keep this diagnosis, because it is just, you know, if you don't put nevus simplex in the way it is put in this list, then it is not a vascular anomaly that needs treatment, or a vascular anomaly which is going to aggrave, to become worse, and it's going to make problems. It is probably going to disappear with time, but sometimes it stays a little bit redness lifelong. I'm not sure that it will induce confusion to parents, because the doctor is the one who is telling the parents what it is and if they should be worried or not. It could theoretically induce confusion to doctors, but I think it is quite clearly described. This is my opinion. If you don't have it there, it's just you're going to miss it. And all the time the question is popping up, what about nevus simplex? And if it's there, nobody is saying something about that.
Okay, great. So another question for KTS, are drugs an option for patients over 25 years old?
Once again, I'm sorry, I didn't understand you well.
Sorry, for KTS, are drugs an option for patients over 25?
Actually, we are not experienced in adults, so we are coming from the Department of Pediatric Surgery and treat them until 19. But I will tell that drugs are always an option from KTS. It depends only if KTS is proliferating or not. Whenever Klippel-Turner syndrome is associated with proliferative tissue, so a lot of lymphatic tissue, and also small capillaries, I am quite sure that the drugs will help. Okay, but I don't have personal experience with adults.
So perhaps I can just add to that, that the trials that we are doing in Brussels, and I'm sure in other centers with off-label, in the centers that are treating adult patients. So definitely, like Dr. Haxhija said, the adult patients also respond to those therapies, but it depends on various aspects, like he said. And most, I mean, not even, I don't even want to say mostly, we are still learning, but definitely there can be benefits.
Thank you. There's one question I'm not quite sure exactly. It says, if we have doubts about a case, where can we ask? I don't know if that's from a medical professional, but there are the possibility of, if you have a difficult case, to contact our network and they can be discussed.
Yes, the VASCA working group chairman, I would say, or would be the solution.
Yeah, if you have a national network already, you can already contact someone there, or if not, you can contact VASCERN on our contact email, and then we can transfer it to the VASCA group so they can see if they can help with that. The next question is it obligatory to get blood work done, brackets concerning possible transient thrombocytopenia or others, for every vascular anomaly, no matter what?
Paolo, would you like to go?
So just for some kind of tumor is not important to work out the eventually transient thrombocytopenia, but not for all vascular anomalies. For example, is really important if you have the suspect of a caposiformis hemangioendothelioma, for example, but not for all vascular anomalies.
Okay. Again, this question, I'm not sure if it really applies to us. It says, is there a list of laboratories that we can contact for genetic confirmations of some complex vascular anomalies after performing biopsy? That's probably a question for your national, you know.
I would actually like to answer that question,
yeah,
because
sure.
It is a very important question, actually. The point is that thank you for this question. For example, in our institution, we do not have those problems, because we take the tissue and send it to our genetic lab, and then we wait for 5 years and then we get the result. No, it usually is faster, but sometimes it really lasts a lot until we get the result. Probably it is because we are not that focused. Sometimes we do not know what exactly we want, and then we send a material and say, please analyze it genetically and give us the result, what this could be. Today, we have to know in front what kind of genetic malformation or genetic mutation we are looking at, so that we get this information faster. And to my knowledge, we don't have a list of laboratories where, for example, people from Africa or wherever can send a specimen if they do not have a genetic laboratory in their own country. But I think that this is a very, very, very good question. And maybe, Miikka, there is really a possibility to do something on the European level and see what genetic laboratories Europe-wide would like to offer this kind of expertise for payment or however for analyzing a genetic material from any institution in Europe, so that it can be sent to, and probably then some institutions or some doctors doing biopsies and wanting to know what is the genetic background of their patients will profit from that kind of service. What is your comment on this, Miikka? Because I think this is really a very important question, and is going to help a lot to patients in countries where they do not have a readily available genetic service.
Yeah, so we have a genetics sub-working group within the VASCA working group. And so in all the 7 centers that are already linked to VASCA, there's basically a genetic service, and we try to harmonize now all those genetic tests, whether it's germline or tissue, that can be done and that we give similar answers, because there are some discrepancies. But people from outside can definitely send. We do lots of genetic diagnoses for samples that are not from Belgian patients, that they come from abroad, just for like any international patient that can be done. Of course, the reimbursement rate depends on the country, and usually it may be that the patient has to pay that from his or her own pocket, unless that country's healthcare system will take in charge. But so shipping samples and having them analyzed is definitely a possibility. And so in several of the Western countries, at least, we have laboratories that especially perform for the tissue samples the cancer panels, and those are very widely spread already in many, many places. So it might be that because you are in, where was it was marked, that you were from Belgrade, I think. So it might be that you still have a cancer panel service in your hospital. And those cancer panels actually have many of these genes that Emir was describing here in the classification. We have exactly the same genes, except the TIE2, which is more specific for vascular anomalies.
But Miikka,
ACA, for example.
I'm sorry, Miikka, but is there on the VASCA website, is there an address of the laboratories where they could contact, or an email address and send the specimen?
I don't think we have that yet, Natasha, but it's true that we could list the laboratories that are already in the genetic working group.
Yeah, this would be a very, very good actually outcome of this this lecture today.
Yeah, we can do that.
Okay. Yeah, and again, this is a question, I guess, again for Miikka. Maybe talk about, are you keeping a centralized database, natural history studies for vascular anomalies? We need collective collaboration across the globe.
Or rather, perhaps for Leo. Is Leo there in the?
Yes.
So I don't know if he can come in, but I can start before, perhaps. So we are making a VASCA registry. That Leo Schulze-Kuhl from Nijmegen is in charge. We really want to have that as an interactive registry where the different centers still own their data, but everything would be standardized. And it would be possible to link that registry with the FAIR database kind of basis to other registries. So this is an extremely important point to be able to follow patients, but also to know already what the incidence and prevalence are and where are those patients. So yes, this is a very important point for VASCA. Thanks for the question. Can Leo connect, or he's...
Thanks for explaining, Miikka. I think it was quite clear. Basically, EU is setting up for all rare diseases FAIR-based registries. So that also among other ERNs, we basically can look at mutations and see if there are common things. For VASCA itself, like you said, basically all the VASCA centers are now setting up on the registries and connecting those. So probably within a couple of years, we'll get more information about natural history and so on.
Thank you, Leo, for joining us. There's a question. I'm not quite sure if I understand the question. It says, I have not understood for therapy which drugs for hemangioma for patients.
Okay. Yeah. I could comment on that. Today's lecture was actually about the classification, not about the treatment. I do really think that we are going to have webinars on treatment of various vascular anomalies, but for separate ones, which I've talked about today. And for hemangioma, you have to see what kind of hemangioma it is, so that you find or you can know what kind of treatment you will offer. So first you have to know, is it an infantile hemangioma or is it a congenital hemangioma? And then if it is an infantile hemangioma, you have to know if that hemangioma needs a treatment or it does not need a treatment. And it is something that, of course, there is not a recipe for this, but there is some experience that you have to have, and colleagues, at least older colleagues and others in the group, which you can consult and decide if a patient needs treatment or not. Of course, if you have a patient with infantile hemangioma spread all over the face and so on, growing fast, you will need treatment. And the current treatment for infantile hemangiomas with need for treatment are beta blockers, oral beta blockers.
Thank you. This one is more of a comment maybe. Did everyone know that there is now a biomarker for Kaposiform lymphangiomatosis, angiopoietin 2?
Thank you.
Yeah.
Thank you. Great.
Yeah. And so it was, I think, a follow-up to the registries. Would collaborative biobanking plus registries be important for developing the classification of vascular anomalies even further?
Yeah, probably yes. I mean, collaborative biobanking is something, and registries to be built up. I think we are working currently on that. Their importance for developing the classification even further, I think, definitely yes. But I think first we have to build up this.
Yeah, I see Leo, he wrote in the comments that the collaborative biobanking and the registries will be extremely important for this. The registries are set up according to the FAIR principles, which assures optimal data sharing. So thank you, Leo.
And just comment, so within the International Society for the Study of Vascular Anomalies, or ISSVA, there has just been the setup of a new working group to think about the whole classification and how to make it even more kind of approachable, because it's getting more and more detailed. So there's actually a working group that has been set up, and there will be work continued until next ISVA meeting next year. So we will see what that working group is able to come up with, but I still think that the biobanking and more genetic data will help classify the lesions. Yeah, thanks.
Great. And I think this is the last question for now. How many hemangiomas are necessary for hemangiomatosis?
This is a nice question. This is really a nice question. The point is that the hemangiomatosis is, it does not really have that kind of definition. It could be more than 10, but we sometimes see like 50 small hemangiomas, and then they could be on the skin, and they could, of course, then be also spread intra-abdominally or in some other visceral organs. And important is that the hemangiomatosis, a case like that, just needs a diagnostic workup so that you see if there are more lesions than you see on the surface of the skin. And this is the important part in patients with hemangiomatosis. We have seen also a number of patients with hemangiomatosis without any visceral lesions.
Great, thank you. There's just a comment, and I don't know, there's not really any other questions, I don't think. Bravo from Guillaume, Jando, our coordinator, thank you. So I don't think there's any other questions. Can maybe close this session, and with a big thank you to Professor Haxhija, Dr. Paolo Gasparella, our special guests, Professor Miikka Vikkula and Professor Leo Schutz-Kuhl, the chair and co-chair of the VASCA working group. And thank you all for joining. We will have this webinar available soon on the website and on YouTube. And please stay tuned, follow our website and our social media channels for news on the upcoming webinars. And thank you, everybody.
So there was one I see for next meeting, can you present more cases? That's actually something, not the cases, but kind of a call to everybody who is there. If there are any topics that you think would be of interest as such, please let us know. The ideas that we currently have is to go through the patient pathways that Emir very quickly showed, but much more in detail. But there might be other topics that you would be interested in. Thank you.
Thank you. Yeah, we got some good topics in the registration form that we'll share with the group. And so if others have more topics, they could maybe put that in the registration form again. So yeah, thank you, everybody. Yeah.
Thank you, everybody, for being present here today. I hope really that I could actually fulfill what I intended to today. One was to show you the possibility of mixing up different lesions between different vascular tumors and maybe also between vascular tumors and vascular malformations. Then I wanted to point out the crucial role of imaging in distinguishing between different lesions. Then also the crucial role of imaging in distinguishing between localized and diffuse vascular malformations, because that is important for treatment. And I didn't really talk much about pathophysiology, and yeah, I'm sure we're going to talk about that in future. Thank you very much to all.
Thank you very much to all.
Thank you, everyone. Wishing you all a good night.
Thank you, everyone.